morning and welcome to day 2 of Connect Karo. I hope many of you got the opportunity to hear the minister and attend the first session. This particular session looks at another of WRI-India's key areas of work and looking specifically at energy for equitable health outcomes. We know in India, there's been significant progress made in achieving universal or near universal household electrification through targeted interventions by the government, especially the Saubhagya scheme. But in contrast, the same push has been lacking towards electrification of critical social infrastructure like health facilities and schools, and also rural livelihoods. Now, this is important because the focus on individual house and household level is often the way we think about energy poverty globally, especially in the sort of global north, where the focus is often on households and individuals. In the global south, we have tended to define energy poverty as primarily being about access to adequate infrastructure and security. And the progress in household electrification often masks these significant gaps that exist in energy services reaching health sectors, education, livelihoods, and so on, particularly in rural and remote parts of the world. Now, given India's goal of achieving universal health coverage, it's essential now that we sort of bring these two together. And this work became very important, and I think during the COVID-19 pandemic, when reliable electricity for basic health services, but also the special needs at the time for vaccine storage, for oxygen concentrators, other critical equipment became pretty apparent. They were not available in many parts of the country. So let me just briefly talk about 3 aspects of our work on energy for health. The first is a partnership with HSBC India on providing decentralized renewable energy plus batteries and so on for non-profit and charitable health facilities who are an integral part of the rural health care network. We have a sort of tripartite partnership with HSBC India and sort of collection of rural hospitals where HSBC spends their CSR funds towards helping set up the electricity service, energy services in rural hospitals. Over the last 4 years, we've helped. This arrangement has helped set up several healthcare facilities in Jharkhand and in Maharashtra, but also increasingly in Rajasthan, Assam, and so on. Our interest is to sort of look at, so what changes, right? Now, we've seen this in many parts if you look at the sort of the electrification information, as more and more districts got electrified, the HDI indicators sort of remain the same, the rest of the HDI indicators. So the same question we asked ourselves, what is changing? And so we have been documenting what's changed at the healthcare facility level in terms of increased patients that are now being able to receive treatment or support, in terms of new medical services being provided, and so on. And I think we have an excellent panel that's going to sort of flesh out some of these learnings. We have, as I said, similar partnerships outside of the HSBC relationship. We have other partnerships in Rajasthan and Assam, and I think we'll hear a little more about that through the panel. That's one of our efforts. The second is the Energy Access Explorer that I hope some of you have seen. This is an open source GIS-based platform where we've been really looking at how EAE can be used to help state governments improve their planning for electrification. The EAE offers a sort of multi-criteria prioritization, and so, for instance, the Jharkhand Renewable Energy Department had this mandate of solarizing 100 healthcare facilities, they were able to use the Energy Access Explorer to help prioritize which are the 100 that are most suited. Obviously, they had to be those places that didn't have reliable electricity, irrespective of whether they were on the grid or off the grid, that they had pretty decent solar irradiation and so on. So the Energy Access Explorer allows you to use this multi-criteria approach to prioritize. So the JREDA use is one such example. We've now got the Energy Access Explorer information in India for Jharkhand, Assam, and next week, actually, we are going to launch this in Nagaland. But also in other parts of the world, and my colleague Benson is here, who may talk a bit about how WRI has helped governments in East Africa. So that's the second thing, the Energy Access Explorer. And the third is that we have sort of right through this worked closely with the WHO, with the World Bank, IRENA, SE for All, in developing this joint global report on energizing healthcare, which provides a much needed baseline for electricity access and provides insights on how to accelerate health facility electrification while supporting the transition to clean and sustainable energy systems that improve health and climate outcomes. WRI is also part of the Multilateral Energy Compact for Health Facility Electrification, convened by SE for All and Power Africa, along with other partners like Selco Foundation, and hope to continue to contribute to more national and regional assessments to create better data and recommendations for implementation of renewables in health facilities. With that, I'd like to now invite Dr. Panda to share a few words with us. Dr. Panda is currently a senior fellow at WRI-India, and he has had a long and distinguished career in the government of India. He served as the additional secretary, the Ministry of Health. He was mission director of the National Health Mission. He was also director general of the National AIDS Control Organization. He's been a strong support to the team, not just the health sector, but also some of the other work, because he also has spent a fair bit of time with the MSME sector, another area of interest to us. With that, Dr. Panda, over to you.
Good morning. Thank you, Bharat. Welcome to all participants, everyone who has decided to come and contribute and to learn from this particular session, which is going to explore the synergies between the access to energy, reliable energy, electricity, and the health outcomes. If you really look at the investments in government, in the government sector, I'm not talking about the government, both central government and the state governments in the last 15 years or so, because the National Rural Health Mission started in 2005. And thereafter, there was another component of the Urban Health Mission, which was there. And finally, it kind of merged and it became National Health Mission. This is an investment which is done, as you must be knowing, on a sharing basis between the Government of India and the state governments. And this has had tremendous impact on the improvement of health outcomes. If you look at, all the different health outcomes in the, if you take those criteria, there has been real improvement, and it has been going on. And finally, a few years back, the Government of India actually started the Ayushman Bharat, which has two components, as you know. One is, which is very, very important, extremely critical, important, that the sub-centers, 155,000 sub-centers in this country are being converted to health and wellness centers. Health and wellness centers, which is going to provide a comprehensive healthcare. Earlier, the sub-centers used to be reproductive and child health and the basically immunization and contraceptives and that kind of thing, But now it's going to be, it's becoming much, much wider in its, in its service. In its service, they are providing a whole lot of services, and that's where the the kind of, it is so important because, as you know, the primary healthcare is extremely important in every country, and more so in a country like ours. When we are talking about these kind of work which is going on, they also face a lot of challenges. There have been a lot of improvement in human resource and in various drugs, and the whole lot of Indradhanush, where a lot of vaccines are being provided and all that stuff is there. But one thing which is consistently which is coming up, as a big challenge, that in very far and remote, far-flung areas, uh, having reliable energy access in those sub-centers or health cum wellness centers, that's becoming a big problem, at least in some. I'm told that the latest rural health statistics, give some data which shows 17,900 sub-centers and 900 primary health centers don't have reliable electricity. Some of them don't have access to electricity also. So that's a pretty big number, and people. In fact, I also say that people who live in that area, they need the most. They need the healthcare the most. So it is a matter of equity also when we are talking about that. Now, WRI had released a policy paper 2 years ago, which actually kind of focused on all these issues, the challenges, and what should be done and all that. And there is now a greater need to prioritize, as Bharat very rightly mentioned, to prioritize. What happens basically, you must know, there would be very eminent panelists. Dr. Bhushan is here. I had the good fortune of working with him in the health ministry. He's an expert in all this, and he's going to definitely talk about that. Now, what happens when a particular state is given a particular envelope, a resource envelope, in the sense a particular state on a particular formula is told that, okay, you are going to get, let's say, X amount of money. You prepare your own action plan. So in that, the state needs to really prioritize using, the EAE that you talked about and many other things. They need to really prioritize so that at least these sub-centers and primary health centers should have reliable access to electricity, reliable electricity. It's not just that something is electrified. A lot of power failures, power outages and all that. So that creates a big time problem, a very big problem for the cold chain, for the many other medical devices, for newborn centers. The whole lot of challenges are there. So that's why, and there when we talk about that, I'm very happy to see a gentleman coming from, he is going to talk about East Africa. I had the good fortune of actually seeing many of the projects which are being undertaken by International Solar Alliance. I was with them for some time. And there I saw that some places in Africa, they have actually taken up the solarization of those health facilities in a big way, and rightly so. And perhaps, a time has come when we have to really look at it. We means the state governments in particular have to look at it. It's good that the new IPHS guidelines, so that guidelines actually have come up with, and that's very clear that this should be given the right priority, and this is a step in the right direction. And so when we're talking about energy access, we are talking about not just traditional energy access, to electricity and all that, grid electricity and all that. It should be also renewable energy, the solarization, and if a particular place has got access to wind energy, so be it. So it has got so that can be reliable energy. Now, when we do that, we should not forget the challenges, like the DISCOM's role, the distribution companies' roles. Sometimes they are little unwilling and all that. I happen to be also, I'm associated with two of the, those distribution companies, where we keep talking about this, because these days the independent regulatory commissions are also giving them a target that, you have to use this kind of renewable energy, in the energy, that entire in the total energy that you are consuming, you have to have certain percentage of solar energy. So So, but when we are talking about that, there is obviously a challenge of financing, getting the finance, low cost financing, then installation, and most importantly, the maintenance. If you see in many places, the maintenance is a big issue. So we are talking about annual maintenance contract, which has to be there with heavy penalty if somebody is not able to do that. And I'm sure if there is a critical mass of these kind of cases, there would be, those companies professionally who would be coming forward and would be doing it. I'm sure they're also doing it in some places, but that's something that we need to really take a look very, very closely and very carefully. Now, there are interim findings of a study that Mr. Lanvin is going to talk about, and so that will be presented today. That's very, very interesting, and we'll be really looking forward to different suggestions or advice, and from all those experts, and we have in this panel. And then finally, once that final report comes, and of course it will be kind of it'll be updated from time to time, because we must understand that everybody, like the energy service provider, the renewable energy service provider, the discoms, the state governments, and non-government organizations and experts like WRI and all that have to come together, so that at least we can achieve all these centers, these sub centers, health and wellness centers, and the primary health centers can have access to reliable, steady electricity, and so that it will people. So this will, and also the development partners, people who are here. As you said, HSBC is you have association with them. So I would request all of you to kind of that, and then WRI should also take it up with other states. For example, you talked about Jharkhand, Assam. I understand all those states, but there are other states as well where, for example, in Odisha there are places, in Chhattisgarh, in other places where there are huge need, even in Madhya Pradesh and Maharashtra, Gadchiroli, and there are Chandrapur and all that area. So there are, in every state, there are certain pockets where, there are big challenges. So we need to really take it up separately with the state governments, individually, tell them that, look, this is EAE is a tool that they can use, and they can go ahead and prioritize it. Thank you very much for your patience, and we will be looking forward to this great discussion by our panels. Thank you.
Thank you to Dr. Panda and Bharat for setting the stage and the context. And a very good morning to all of you, and welcome to Connect Karo. So let's dive right into the presentation first. And this study, as I mentioned, is undergoing a peer review currently, and therefore the preliminary findings are being presented, and we hope that you'll all be also here for the report launch, which will take place in a few months. So as Dr. Panda has already briefed the situation in India, but also globally, nearly 1 billion people in low and low middle income countries are served by health facilities without reliable or with no electricity access at all. In India, as Dr. Panda mentioned, the numbers are still pretty significant in terms of those which do not have electricity supply. But we have renewed Indian Public Health Standard guidelines that promote the use of renewable energy with battery storage for climate resilience, but also energy efficiency measures and procurement of energy efficient appliances. So why this study? We know that electrification is a critical aspect of health infrastructure and urgently needs more attention from governments, development partners, and donors. But decentralized renewable energy, particularly solar, has proven to be cost-effective and readily deployable without having to wait for the grid in locations where there is no electricity access at all. But there's a lack of monitoring and evaluation data, especially in terms of documenting the long-term outcomes in terms of health service delivery, and also a lack of track record data on the existing DRE projects in terms of public-private partnerships that have taken place, and also contracts that have been in place to electrify health facilities. So the research we're trying to do is to look at how DRE affects provision of rural healthcare service delivery. What are the current practices for financing, procurement, installation, operation, maintenance, and capacity building that are in place? And are these practices currently sustainable? And if so, how can they be made more sustainable so that we can scale at the path we are going? For the study, we looked at a sample of around 22 health facilities across 6 states. But just to mention that this sample is part of a number of engagements with our partners who, just those who have mentioned here, have electrified over 3,000 healthcare facilities through solar in India, combining to up to around 6 megawatt of solar PV installation. So yeah, we're very much past the pilot phase. We are truly in the scaling phase, and we need to. And I'm sure there's so many other partners here who have worked also on several more projects that we've not covered actually in this project. So we've covered facilities from public health facilities to not-for-profit health facilities, as Bharat mentioned, who play a critical role in rural India, to also other forms of healthcare like boat clinics, who play a critical role in some of the riverine island regions. We've looked at solar installations, both ground-mounted and roof-mounted, across various financing options and various technology configurations. What the scope didn't cover was mini-grid-based electrification and mobile clinics, which, again, have the rightful place and play a very important role as well. So the findings that we've done are at a facility level, where we've done surveys at the facility level and then backed them with interviews with government departments and implementing organization and development partners as well. Just some of the keywords of the study, they cover so many themes, but given that we've only got a very limited time, we will just touch upon a few of the themes, and we'll be happy to discuss more later on, and you'll of course read more about it in the report coming up. So firstly, assessing the energy needs. Bharat of course mentioned EAE as a tool, but energy needs assessment have been usually done at health facilities. But when the DRE systems that have been installed, they're generally limited to certain services or certain appliances or certain medical blocks within a larger health facility, especially as you go to the larger tiers of healthcare. The most commonly connected appliances have been lights, fans, vaccine storages, cold storages, especially for vaccines and blood banks, but you're also seeing a lot of equipment in maternal and child care being connected. But many high power consuming loads, like geysers, water pumps, X-ray machines, sterilizers, have been generally left out because of the limited size of these PV systems. And so also most of the facility that we interviewed actually had a grid connection, but with varying level of power outages from 2 hours up to 14 hours per day. And many still use diesel generators as well for services that are not connected to the solar PV system. So, in short, DRE in most cases has been a complementary energy solution and not necessarily a displacing one. So it hasn't really eliminated a diesel generator. There have been, of course, examples 2 or 3 out in the study, but mostly it's been a complementary energy solutions with the ability to displace the diesel fuel or the electricity bills and reduce them. Another thing is procurement, where we sort of took the view of a lot of technology vendors. Some of them actually stayed out of public procurement at scale because of the bidding method, which is the least cost bidder method, where the least cost of the solution was considered the best. But many technology providers mentioned that at the least cost, it was tough for them to provide very high quality equipment, and then so they had to be very selective in the type of solutions they went ahead with. On the other hand, there's of course a challenge of incentivizing timely delivery of O&M, and that's something Dr. Panda mentioned, that they are long-term AMCs, but generally there is a either lack of follow-up from the health facility or a lack of regular visits by the vendors on site. A lot of this also happens due to the limited annual term financing that a lot of projects have, right? So it's a one-time payment which happens to vendors, and then how do you ensure that they will actually come for the next 5 years? How do you really incentivize that? Some good practices we observed in Meghalaya and Jharkhand, that procurement contracts were actually divided in a sort of a result-based financing mode across 3 or 4 tranches. So there's only a limited portion paid in advance, but then there's some tranche kept for delivery of materials, and then also a lot of the the money that actually went to the vendor was after the installation, after verification of satisfactory working of the energy system. In Chhattisgarh, very rigorous procurement policy where they paid 0 advance to the vendors, and 95% of it was paid only after installation and commissioning. Now this is of course possible because the solutions at scale, there are a lot of sites, but also because of the trust a lot of vendors have in the government entity to do regular payments and on-time payments. So because of that, so vendors were more comfortable with accepting no advance payments in these cases. Incorporating energy efficiency in built environment are critical and can help optimize energy demand as well as utilization of the DRE system, but are often not prioritized at the start and are generally become an afterthought. So people go up, put up solar PV systems, and only then think about, okay, energy efficiency, you need to put in new bulbs. So we have seen a lot of sites, some examples here from Meghalaya is that there is LED lighting and BLDC fans incorporated, and also we have seen a lot of work in incorporating energy efficient vaccine storage storage devices, and radiant warmers in maternal and child healthcare. But health facility staff are actually keen on integrating more energy efficient appliances, but they need simpler metrics, like star ratings that we have for fridges and air conditioners. If something of those sorts can actually be inculcated in medical appliances, that would be much easier than to actually decide between different type of technologies. And we did see the benefits of solar, qualitatively, of course, felt by a lot of the people there, but they're rarely tracked from the perspective of energy consumption or savings or emissions reduction. And in these cases, remote monitoring systems actually play a significant role in tracking these and have been used in models such as energy service models, or the RESCO models as we call it here, but not often in off-grid solutions. And the challenges here that have been highlighted primarily associated to network availability, because the study looked at rural remote regions. So internet connectivity was once an issue, and even if it was there, then the facility had to actually invest in a new Wi-Fi router and pay internet bills, and all of this is not really covered in any contracts currently. But yeah, it definitely needed to overcome those. And as you'll see in the bottom right, they actually looked at physical digital energy meters as an other option, where staff can actually just record the generation and consumption in the month and have a better idea as well. So staff environment, another some interesting insights there. So a lot of staff quarters are generally connected to the health facility or are adjacent to it, but have in most cases remained disconnected from the solar system that's powering the health facility. And that's because of perhaps how the policy is designed, that the staff living at these premises have to pay their own electricity bills for the quarter and also have to arrange for their own inverters and UPS backup. So they're not covered under the health facility. So I think that definitely needs to change. And we've seen the positive impact of that, of course, on the solarized boat clinics, because over there staff had to travel to these riverine islands, live for a week around the boat to conduct the health camp and then come back. So over there, staff mentioned that just having battery storage in the night enables them to be connected to the mainland through mobile charging and internet, but also for female staff who felt most secure around the boat and allowed them to move around the vicinity of the dock boats in the evenings. Operations and maintenance, we have actually seen good awareness about cleaning panels and topping up of batteries amongst health facility staff, but the frequency remains uncertain. So people generally have an idea that, okay, a notion that every 2 weeks or every month you clean your panels, but in different sites the situation is so different. Some of the locations were close to coal mines and iron ore mines where dust settles in the panel almost every other day. So if you don't clean that at that regularly, then it's not going to work as well. And similarly with battery topping up, some areas which were really hot or where the batteries were continuously used, the top up was needed to be more frequent. And so cost associated, very simple cost, but cost associated with distilled water also is something that you need to consider. We have seen annual maintenance contracts integrated where vendors have to sort of come every half yearly or every year to maintain these systems, but whether the health facility should be the one to call the vendors to the site, or whether the vendor should be ready to come every 6 months, that's something that we need to also find a mechanism to incentivize this to happen regularly. And a lot of the maintenance responsibility actually falls on the health facility staff, which may be seen as a burden. So some sort of incentive for the staff who is doing this is also, of course, necessary. Again, some practices that we observed in Chhattisgarh, for example, the government entity had their own dedicated field service units who took care of the maintenance. So basically zero burden on health facility staff. In Meghalaya, for example, very simple yet impactful posters in vernacular languages attached next to the inverters and the battery system really help them understand what the basic operation maintenance are, and also for any new staff which comes in, because there's so much staff turnover, this such of practices actually helps them understand better. And lastly, financing. Of course, Dr. Panda mentioned a lot of state program implementation plans can actually include RE-based electrification in the budget, but we've just seen very few examples of that happening. Also, there's a need to unlock various state-specific budgets, like for states which have district mineral foundations, aspirational district programs, the MP and MLA local area development schemes, untied funds, and of course, state government's own budgetary allocations can be tapped into. Not-for-profit facilities, on the other hand, are primarily reliant on CSR and philanthropy, but CSR and philanthropy also have a role to play in solarizing public health facilities and bridging any financing gaps there. One important challenge we saw is the challenge of repurposing existing PV facilities. So we saw many examples where there were old plants installed, 3-4 year old, not working, and then new grants come and a new plant is installed without any sort of bother about the older plants. But we need to ensure that there is equal financing actually going towards replacing of batteries or reusing of panels, even though it might not sound as shiny as a new solar PV system installed. And of course, the need for long-term financing and patient capital is essential so that we can actually showcase long-term outcomes in the healthcare service delivery space. So just to conclude, the DRE interventions have a role across all the 6 building blocks of a WHO health systems framework. The better provision of service delivery was observed in many locations through greater autonomy, especially through battery storage integrated with solar PV. It showed the creation of a conducive work environment for both clinics especially, and needs to also be considered for health facilities through solarizing staff quarters. In health information systems, the HMIS is already extremely robust, but adding further energy system data can help also track other impact that are needed. The role of energy in vaccine storage is of course very clear in the past 3 years, but energy efficient medical equipment is essential to ensure that we optimize the energy demand. Financing, the need of the hour, again, as was already mentioned, convergence of public financing, CSR and philanthropy, and also long-term financing and patient capital is absolutely essential. And governance, right? So Dr. Panda mentioned, we need state governments to take leadership in a lot of the health facility solarization for public health facilities, but also establishing accountability at the ground level at the health facility in terms of operations, maintenance, and ownership of this energy system is absolutely essential. So thank you so much. I will now pass it on to my colleague Harsha for a panel discussion, and then we will take forward with questions. Thank you.
I'm grateful to Dr. Panda and to Bharat for setting up, the stage for this discussion that we'll have today. And, it gives me great pleasure to introduce to you all of our panelists. We have an expert panel today, and I hope that they'll be able to delve deeper into the issues that Lanvin just highlighted in the presentation. So, let me invite Dr. Himanshu Bhushan to the stage. He has worked as the head of the Public Health Administration Division of the National Health Systems Resource Center. This is the technical support wing of the Ministry of Health and Family Welfare. Dr. Bhushan has actually been instrumental in many policy decisions, including the Indian Public Health Standards. And also the health grants under the 15th Finance Commission, and also initiatives such as strengthening district hospital and dedicated maternal and child health wings in health facilities across the country. Let me invite Nirmita Chandrasekhar, who is a senior program manager with the Selco Foundation, where she leads the built environment portfolio while anchoring core programs in health, livelihoods, and cooling. She's an architect. She has an extensive experience in the construction, energy, and development sectors. Please welcome Romit Sen, who is the Senior Vice President, Corporate Sustainability at HSBC India, where he leads the community investment initiatives in the areas of climate change, skill development, and he's also served as a member of the Ministry of Jal Shakti's Committee on Water Use and the technical committee member of the Alliance for Water Stewardship. I also welcome Preeti Bhatnagar to the stage, who is the operations manager with Basic Health Services. So she's the BHS generally BHS provides primary healthcare services to remote, high migration and underserved marginalized populations in Rajasthan, and they do this through a network of Amrit clinics. And Preeti ji has held various roles during her career with the Parivar Seva Sansthan as a counselor, clinic in charge, operations manager, and she's with Basic Health Services now. Please welcome Mahina Vara, who is the program manager at Good Energies Foundation by Porticus. So this is a private philanthropy. She manages the partnerships in Asia and in the areas of fair transition, clean energy, and youth civic engagement. She's also worked for BRAC in Bangladesh, with the ILO in Jordan, and several other think tanks in Bangladesh and Australia. And finally, it is my pleasure to invite Benson Ireri, who is World Resource Institute's Energy Access lead in Africa. His work focuses on accelerating the deployment of clean energy in support of SDGs, including providing strategic inputs to all the engagement that we do in East Africa. So, A warm welcome to all our panelists, and really thank you for being here. Um, we've had a bit of a stage setting in terms of some specific points that Landman also raised, which we will also highlight in our forthcoming report. But we saw the statistics that Dr. Panda talked about, and Landman also highlighted them. And these are the gaps that in electrification, especially at the sub-center and the public health center, in the public sphere at least. So let me start with Dr. Bhushan, and if Dr. Bhushan, you could touch upon a little bit on how does the central government and the Ministry of Health and Family Welfare actually approach provisioning this 24/7 electricity supply, reliable electricity supply in health facilities using renewable energy, and then maybe if you could also touch upon how the center sees it and how the states see it from your experience in working with them.
Now, as far as government of India is concerned, this is now the open, fact that renewable energy and particularly the solar energy is a big focus by the government. And this focus has also transformed to the Ministry of Health and Family Welfare. First time the revised Indian Public Health Standards 2022, because I would like to clarify that Indian Public Health Standards, which are first created in 2012 and now revised again in 2022, it has main focus on the health, and it starts from the services. What are the types of the services, the various services, right from the sub-center to the district hospital, it should be there. And then accordingly, the human resources, the infrastructure needs, the equipments, the drugs, the diagnostics, and also the governance. So governance part, particularly, and quality assurance has been covered this time. And in the infrastructure, we have talked lot about the energy requirement of the health facility, because one of the very important thing that all of us must know, that what has happened since now till now, that equipments are purchased, but while creating the infrastructure there was no planning for installation of those equipments. As a result, the power point, plugs, and these are all haphazard. And nowadays, the sophisticated equipments are coming to the health facilities, and voltage fluctuations and other things, it tends to destroy. So we have, as a policy, we have said that the clean electricity and the quality of the electricity, voltage fluctuations while building in the infrastructure, and wherever the infrastructures are built, because this is again, as Panda sir also said, that the infrastructure is already there. Our honorable minister also said that the infrastructures are already there. How to make it more resilient, and then therein these things should be incorporated, and alternate source of energy, and then finally the focus on the solar energy is now a commitment, and it's a policy now as far as the government of India is concerned. So now coming to the states, that how states see it and how the NHM. I would like to second the presentation given by Landman, that there are already resources are available through the various channels. National Health Mission is the one channel, and again Panda sir said that states are free to put in their project implementation plan, which they are submitting every year for the funding resources to the Ministry of Health, their needs for the solarization. And if that is there, then of course the funding is there, besides so many other sources which were given in the presentation. Now the challenge is that many of the challenges again has already been highlighted in the presentation, but I would like to repeat. Almost 10 years back, one of the largest state in the country was given this solar energy in a big way to all the sub-centers, but later on when we observed, it was not functional. And it was not functional not because the equipments were bad, probably the regions which were explained during the presentation. So what I personally feel is that you have this policy, you have this tool, you have developed a nice tool. I was going through it, and all the energy requirements in the tool has widely been covered. You have the partners who can support you in putting it up. You have the opportunity and you have the fundings. But need of the hour is that states' commitment, advocacy at the state level and district level. that orientation of the district. Such workshops should be organized, more frequently with the state and district people, where people understand why it is so needed, how it can be installed, how it can be maintained, and then along with this advocacy, assessment, funding, specification is one of the very important aspect, because you talked about it and you rightly said about the specification that in India, in government system, we go by the lowest code. But if the specification itself is robust, then only such companies who have good products will come, and then of course we need at least 3-4 companies should be there, so that the competition is open. Then installation, training and maintenance, these are some of the aspects which needs to be covered while we are wanting it to do it. And at present, the more focus is on the sub center and health and wellness center, but states need to put it up for all the critical care areas of a hospital, be it a operation theater, be it is the lab, be it ICU, HDU. So these needs to be covered, but this sense, this feeling, this commitment from the state and districts, in my opinion, are still not upfront coming, and that's why this partnership and this forum is very important and needs to be more elaborated. Thank you.
Thank you so much for your comments, Dr. Bhushan. I think that's very right. Maybe we will take this forward and do these kinds of discussions at the state levels as well, and cover a lot more ground and try to convince them to adopt these solutions. Let me ask Nirmita. So Nirmita, Selco Foundation has implemented 2,500 pilot interventions. I think 2,500 is not a pilot number anymore. But could you speak a little bit about what have been your learnings from these pilots, and what would you like to take forward in the next stage?
When we started our work in Energy for Health, largely we were looking at powering health facilities at the last mile. This was back in 2015, 2016. There were work happening before, but as a programmatic approach, it was in those 2 years that we began. And largely the work was happening on looking at energy efficient appliances, looking at what kinds of system designs are required at the last mile. A lot of the innovation work was happening with health partners and government stakeholders to again look at what that delivery mechanism needs to look like for affordable clean energy solutions being deployed on the ground. A lot of our initial sort of evidences that we were building was just A, on reliability, B, on looking at transaction costs, reducing for communities, end users on the ground, patients who need to access these health facilities. And we were working in various kinds of contexts, right? Not just in very accessible, plain, contexts where you have maybe had 100% energy sort of security, but also in contexts like in Arunachal and Meghalaya, where you had big issues around just accessing health facilities itself, supply chain disruption, and a lot of the initial support we received at that point were through philanthropic monies itself, because we required that money to build evidence, and Good Energies Foundation was a big support at that point to sort of help co-design this whole program. Over the past 6, 7, 8 years now, and especially during the pandemic, the evidence just strengthened, right? Where a few learnings that came out of, I think, our approach, which now has resulted in this large-scale program that we've launched, was that your major stakeholder had to be health departments. We were initially looking at multiple kind of stakeholders, but the problem is owned within the national and state health departments. The durability of such programs, right? Because a lot of the times, like mentioned multiple times before we came on the dais, you might have investments in capex, but there's just no investment in opex for maintenance of systems. And us working with health departments, we saw a lot of evidence over there that once you create an investment model and showcase with those health departments what it needs to be able to raise these kinds of monies, and even now sort of pilot in different ecosystems, different kinds of O&M models, it becomes very critical for us to be able to look at, raising monies in a very comprehensive manner. And that program design became very critical as a learning for us at that stage. And I think the other thing that came out of us doing the first 2,500 facilities was also just standards, right, for off-grid system, for health facility, for a backup system. I mean, different kinds of models of deploying energy systems, procurement policies, like Sir was mentioning, having robust, specifications of systems being designed, and integrating into tenders and policies with different kinds of stakeholders we were rolling out these programs with, training modules, O&M, implementation plans, right, operational plans that require, so then you're making sure that you're not losing out certain critical aspects of deploying such large-scale programs. And even something as critical as need assessments and energy audits at the health facilities, how that can be done with the medical departments, because that's otherwise a learning that the medical departments did not have, the health departments did not have. So these sort of toolkits and modules became very critical at that point to also be developed, and I think that's become the basis for us to be able to do the program that we are launching.
Great, thanks, Nirmata. I think you're very right. I mean, if the contexts are different, it requires different kinds of implementation models and yes, specifications, standards, procurement policies. That is what will give vendor and energy price and enterprises the confidence to actually interact more with this ecosystem within the health sector itself, because it's not that they've been interacting with it for a long period of time. Thanks so much for that intervention. Let me ask Romit. So Romit, Bharat also mentioned, our partnership with the HSBC CSR wing, and could you talk a little bit about how decarbonizing healthcare fits into HSBC's global sustainability strategy? I mean, how does this CSR group actually approach decarbonizing healthcare? I mean, how does it sit between your sustainability goals?
I'd like to, emphasize on 2 points, and maybe the first part of the submission, the first question maybe would more focus on the India context, and then maybe the second I could, also touch upon some of the global philanthropy piece. So the whole aspect, the premise of our partnership between WRI and HSBC is the Climate Solutions Partnership, which is, a $100 million investment that HSBC globally made in 2020 to address 2 areas in climate. One was energy transition and another is nature-based solution. So in the larger, global HSBC discourse, but more so in the India, I think when this whole discussion advanced, our approach was not to look at one pilot here, one pilot there, but it was about how do you create impact at scale and also, show a certain proof of concept. And that is where, the whole approach to look at as a sector and a sectoral approach to addressing energy needs for bottom of the pyramid population was, factored in. Now on healthcare, and so even when we looked at advancing our energy transition programs, we said that while there is a narrative which is purely on the mitigation side, on the CO2 emissions offset that would happen, but there has to be a strong development outcome, because trust me, when we present it to our CSR committees, to our board, they are interested about climate, but they also ask us question what impact it is going to make for the people. So, this was a perfect example where you could integrate a very strong narrative on climate mitigation, CO2 offset, with a very strong development need with, and the presentation by Lanvin, Dr. Panda spoke and others on the criticality of the healthcare sector. So this is, so we found this to be a perfect resonance where you could address the climate narrative, you could also address the development narrative. One thing, which I would like to emphasize, and more so, from the context of such initiatives, is to where do you do these initiatives? Which geographies do you select? I'll just present 3 statistics, in terms of the 3 states where this partnership has worked. Is currently engaged in Jharkhand. So as a country, of all the CSR investments that is made, Jharkhand's share of receiving CSR investment is 2.52%. And a large part is, because of one agglomerate. But the second state, Assam, receives only 1.41% of the CSR overall investments. The other state, of course, Maharashtra, which of course is the topmost state that receives CSR investments, but the districts where we have chosen, Gadchiroli, is where it is lowest in terms of per capita income. A lot of the HDI indices are lower. So, and our big compliments to Bharat, you and the team for selecting geographies which are not so as to say the preferred ones, when it comes to making CSR investments. So one is, of course, this whole approach, the first point, and the second is about where do you select your interventions, where, of course, need is everywhere, but within that, how you are also able to prioritize the element of equity and inclusion for areas which, say, have largely been untouched from, CSR investments. So maybe, yeah, these are the 2 points, Harsha, which I thought I'll share here to to kind of reinforce as to the approach that we have looked at on energy transition and on our partnership with WRI.
Thanks, Romit. I mean, what you said, the common point between mitigation and development and bringing in equity and inclusion, it seems like that seems to be the main focus of the strategy. And this, of course, it resonates with our strategy as well, to focus on people, nature, climate. And yeah, so I think these both speak very well together. Let me invite Preeti ji to share her experience because you are an operations manager at BHS and you run a network of health clinics. Could you share your experience on procurement, on non-medical technology solutions? Because, of course, you've probably procured a lot of medical equipment, but probably this time you procured energy equipment. How was that, experience for you?
मैं एक छोटी सी बात से शुरू करूँगी इसको जर्नी को कि मैं बहुत सारे लोग शायद कनेक्ट करेंगे, पर हम उस राजस्थान में उदयपुर डिस्ट्रिक्ट की बात कर रही हूँ जो रूरल एरिया में, फार रिमोट एरियाज में काम करते हैं। तो जहाँ पर एक रात को एक पेशेंट आती है जीप में, मरीज को लेके आते हैं, जीप भर के 5-7 लोग आते हैं और नर्सेज हैं, 2 या 3 नर्सेज हैं जो डिलीवरी मैनेज करने वाले हैं। अब वो टॉर्च में, सोलर टॉर्च में या जनरल टॉर्च में उस डिलीवरी को जब मैनेज करते हैं तो चैलेंजेस की बात डॉक्टर पांडा ने भी करी, मिस्टर भरत ने और सब ने करी, लेनविन ने। तो वो चैलेंज से शुरू करना चाहूँगी कि छोटी छोटी चीज़ें कितना महत्व रखती हैं। तो नर्स जब टॉर्च के साथ डिलीवरी करवाती है तो सबसे बड़ी चैलेंज है मैन पावर की, कि एक जना टॉर्च होल्ड कर रहा है, डिलीवरी कराने के लिए उसे हैंड वॉश जिसने कर लिया है, अगर स्टेराइल है तो वो उस दूसरी चीज़ को टच नहीं कर सकती है। जल्दी में कोई उसे ड्रग्स अगर निकालनी है, इंजेक्शन निकालना है, तो वो देखने के लिए भी एक लाइट अच्छी चाहिए, गलती ना हो जाए उसका भी ध्यान है रखना है। साथ ही इनडायरेक्टली एक और चैलेंज होता है कि जो अटेंडर्स साथ में आए हैं वो लोग भी नर्सेज को बार बार पूछते हैं क्या हो रहा है, कितनी देर लगेगी, आगे ले जाएं क्या, क्योंकि गाँव में लोगों की टेंडेंसी होती है कि अस्पताल आए तो तुरंत डिलीवरी हो जानी चाहिए। वो नॉर्मल डिलीवरी में विश्वास नहीं करते हैं, बड़े अस्पताल में जाते ही तुरंत हो जाता है, ये उनका मानना है इतने समय बाद भी। तो उनको हैंडल करना भी नर्सेस का काम है। और साथ ही अगर बेबी वार्मर काम नहीं कर रहा है, लो बेबी बर्थ वेट है, तो वो फिर कंगारू मदर केयर से उसकी केयर करती हैं। स्किल भी उतना ही ज़रूरी है, जो मैं मानती हूँ कि हम कोशिश करते हैं कि क्लिनिक्स में नर्सेस को दी जाए, बिकॉज उस स्किल से वो लाइफ सेव तो करती हैं, लेकिन इतने चैलेंजेस के साथ जिसमें रिस्क हो सकता है। तो मैं यहाँ से शुरू करती हूँ कि कभी क्रॉनिक कंडीशन में कॉल करना पड़ा गाड़ी के लिए या डॉक्टर्स की हेल्प के लिए, तो पहाड़ पर चढ़ के नर्स को कनेक्टिविटी मिलेगी। ऐसी जगह भी हमने काम शुरू किया है जहाँ ज़ीरो कनेक्टिविटी, तो बहुत मुश्किल से। तो ये सारी चीज़ों के साथ अब प्रोक्योरमेंट पे आती हूँ हर्षा में, कि हमने शुरुआत करी सोलर के छोटे से इंट्रोड्यूस 13 में ही बिगनिंग में हमने लिया, लेकिन 500 से 800 वाट, जो कि कैपेसिटी बहुत कम है। प्राइमरी हेल्थ केयर एक बेसिक स्ट्रक्चर है जहाँ पर रिमोट एरिया से, ट्राइबल कम्युनिटी से मरीज आते हैं और फुटफॉल करीब करीब रोज का 50-30 एवरेज है। डॉक्टर्स डे के दिन 100 एवरेज फुटफॉल होता है। वहाँ पर जो सबसे बड़ा चैलेंज एक तो कनेक्टिविटी का है कि 2G सिस्टम ही था, बड़ी मुश्किल से 3G आया है। ऐसे में हमने जो एनर्जी पावर बैकअप दिया, तो इन्वर्टर बैटरी के साथ रोज हमारा एक चैलेंज ऑपरेशंस में है कि काम नहीं कर रहा है, कनेक्टिविटी नहीं है, और टॉर्च भी मोबाइल चार्ज नहीं होते हैं। लैपटॉप अगर MIS की बात करें तो डेटा एंट्री रिकॉर्ड नहीं हो पाते हैं टाइम पे। तो प्रोक्योरमेंट एक बहुत बड़ा इशू था और शुरू से ही हम लोग इन्वर्टर बैटरी पावर बैकअप के लिए एक लिटरली स्ट्रगल बोल सकती हूँ मैं, कि हम चाहते भी हैं कि एक तो फंड, 2 बड़े चैलेंज है, फंड है और रिमोट एरियाज में उनकी फैसिलिटेशन एंड मेंटेनेंस। तो इक्विपमेंट के लिए अगर हम इन्वर्टर बैटरी का स्पेसिफिकेशन क्या होगा, हमारी ज़रूरत क्या है, जनरली ऑथराइज्ड अच्छे वेंडर भी उसको नहीं जानते हैं, वो सुनते ही नहीं है डिटेल। तो हम बताना भी चाहें कि हमारी ज़रूरत ये है, लेकिन वो लोग अपना बताएंगे आप 5 किलोवाट ले लो, आप 3 किलोवाट ले लो, 7 लाख का, 15 लाख का, 20 लाख का, तो जो हम सोच से भी परे है। तो ये चैलेंज बहुत बड़ा हमने बहुत लंबे समय 13 से लेकर फेस किया। 2019 में हर्षा आए थे, मैं हर्षा क्विकली बता देती हूँ। 2019 में हर्षा फर्स्ट टाइम उदयपुर आए, उनसे मिले हम और उन्होंने एक हमारा क्लिनिक बिडावल विजिट किया और देखा। उस दिन से एक आशा तो मुझे हुई कि कहीं ना कहीं हम, सपना था कि सोलर होंगे क्लिनिक में सफिशिएंट, लेकिन कैसे होंगे पता नहीं। तो प्रोक्योरमेंट की बात जब, तो हम लोग फंडिंग के लिए बहुत बैक एंड फोर्थ हुआ, सोलर वर्कआउट नहीं हो रहा था फंड के कारण। तो हमने इन्वर्टर बैटरी के लिए भी काफ़ी WRI से सपोर्ट लिया, लैनविन, ऋषिकेश, हर्षा, कि हम कैसा लें। नर्सेस क्वार्टर में प्रॉब्लम आ रही है, प्रेजेंटली ये खराब हो गया है, रिप्लेस करना है, बैटरी डिस्चार्ज हो गई है। इस तरह की सारी चीज़ों को फेस करते हुए थोड़ी सी आशा बंदी की 2021 में हमको केयर इंडिया ने एक फंड ऑफर किया कि हम 5 लोकेशन है हमारे अमृत क्लिनिक, कि 5 लोकेशन पे फंड करेंगे। हमें लगा लॉटरी खुल गई लिटरली कि 5 जगह कोई फंड कर रहा है। अब उसके लिए जो तैयारियां शुरू हुई, अगस्त 2021 से हमारी तैयारियां शुरू हुई, जिसमें लैनविन, ऋषिकेश, हर्षा तक को हम छोटी छोटी बातों पे मतलब मैं तंग करती थी और वो मुझे सपोर्ट करते थे। वेंडर्स ही कोटेशन देने को तैयार नहीं है, प्रॉपर जो अप्रोप्रिएट एक पूरा RFT होना चाहिए वो नहीं हो पा रहा था। 2 ने विड्रॉ कर लिया, एक ने थोड़ा सा काफ़ी हद तक ठीक किया और हमने जैसे तैसे तैयार किया। लेकिन फाइनली अपसेटिंग था कि मार्च में केयर इंडिया ने कहा कि वो फंड हमारा ख़त्म हो गया है, नहीं दे सकते। देन अगेन हम एक यूनिट के लिए, रावज एक क्लिनिक है जहाँ बहुत फुटफॉल है, वहाँ के लिए हमने ट्राई किया। एक यूनिट के लिए फंड अरेंज भी किया और लैनविन ने सपोर्ट किया और हमने काफ़ी तैयारियां कर ली। लैनविन ने एक विजिट किया था, मेरे को डेट भी याद है, उदयपुर में, और एक वेंडर से कॉन्फ्रेंस कॉल पे बात करी और वो वेंडर हमें सूटेबल लगा कि शायद हमारी सब चीज़ों को मीट करेगा। देन वो चले गए। फिर उस क्लिनिक के लिए हमारा, उन्होंने फिर WRI ने कभी हमें ये नहीं कहा कि बार बार कुछ हो नहीं रहा है। फिर से हमने सारी एक्सरसाइज करी और फिर ये लगा कि सारे क्लिनिक में नीड है, तो अब हम रुक जाते हैं सब जगह। एंड फाइनली सितंबर में ऋषिकेश का एक कॉल आया, 28 सितंबर को, कि आपका एक CSR थॉट वर्क्स करके है, CSR फंड में उनके पास एक फंड है, वो दे सकते हैं हेल्थ केयर में, अगर आप आज ही प्रपोजल भेज दें, लास्ट डे है। मैं ऑपरेशंस में देखती हूँ लेकिन मैं लिखने में बहुत पुअर हूँ, मुझे डॉक्यूमेंटेशन नहीं आता, पर मेरी जो टीम है, थैंक्स टू अर्पिता, उसने उसी दिन प्रपोजल सबमिट किया और हो गया। कुछ कुछ आशा थी, 1 महीने का टाइम था कि तब तक शायद वर्कआउट हो। 1 महीना निकल गया, 1.5 महीना निकल गया, हम तो जानते थे, आदत पड़ गई कि नहीं होगा। और कुछ कुछ अरेंजमेंट बीच में, कॉस्ट इफेक्ट और सब चलते रहे। फाइनली 1 दिसंबर में फिर से ऋषिकेश का फोन आया कि आपका अप्रूवल हो गया है। वो दिन हमारी बहुत खुशी का दिन था कि टीम एंड सारी चीज़ें जो परेशान है, फाइनली MOU साइन हुआ दिसंबर में। और सारी चीज़ें, बिकॉज लैनविन ने एक विजिट किया था, एक वेंडर के साथ जो बात करी थी, वो वर्कआउट हुए। इतनी वर्किंग जो थी वो पेड ऑफ, क्योंकि हम अब तक एक्सरसाइज करते रहे। फाइनल हो गया ऑर्डर फरवरी में, हमने जनवरी में ऑर्डर प्लेस किया। फरवरी 23, 4 फरवरी से 19 मार्च 23 में हमारे 5 जगह इंस्टॉलेशन हो गए। एंड ये प्रोक्योरमेंट में जो टेक्निकल सपोर्ट है, माइक्रो असेसमेंट है, मैंने सीखा, मेरी लर्निंग रही WRI के साथ कि कैसे एक एक चीज़ को कैलकुलेट करके ऑप्टिमल यूटिलाइजेशन फंड का होता है। तो मैं बहुत थैंकफुल हूँ कि उसमें हमें सपोर्ट किया। बहुत हमने एक्सरसाइज करी और जो हमारी रीच से बाहर लग रहा था, तो वो एक प्रोक्योरमेंट का पार्ट है।
Thank you so much, Preeti ji. I'll just quickly translate some key points for those of you who were not able to make it out. So she was explaining that when a patient actually comes at night, the nurses are trying to manage the deliveries in torchlight, and they have sterilized hands, so they can't really change roles whenever it's required. And so if there is no electricity, so then they have to have a lot of different kinds of varied skills they need to have, so that they are able to manage their associates who come with the patient themselves, and provide the actual services that they are supposed to provide. So they started, they had a solar installation in their clinics of about 500 to 800 watts in 2013 is what they started with. And these are really remote areas in where the clinics are located, but they still get about 100 plus patients on the doctor day. These are locations where communications is a big challenge. Power backup is also a big problem there, and so their most of their time has been focused towards trying to figure out how to provide the needs of the nurses themselves who are there 24/7. So she wanted to talk about funds and facilitation of vendors, and the point being that the vendors don't really always focus on specifications all the time, that they may also want to provide them. They have their own mindset in terms of, okay, why don't you adopt this kind of a solution? And so, it's a lot of back and forth with the vendors as well. So they did try some short-term solutions for batteries to be able to meet the needs of their clinics. And then, because I think we've been having a lot of conversations with BHS, and so there was a time when they got a funding offer from Care India, but because it took so long to find a vendor to be able to, provide those solutions, the fund actually expired. And, March 31st is usually when funds expire. But then they did do another round of energy demand assessments. We did a lot of hand-holding with Preeti ji herself and her team, and then decided to do another level of procurement with another funding partner, which then happened in September. And then that vendor selection process was also very long, because there was a lot of back and forth, a lot of field visits and site visits to be required from the vendor themselves. And so, yes, finally, by March end, they had their 5 clinics solarized. So this is, a journey, so to speak, nothing else, and sort of always being championed by Preeti ji here. And thank you so much for sharing that, that experience. But let me invite Mahina, to maybe address some other questions. So, Mahina, Good Energies Foundation has been supporting health sector electrification, and you've done this in several geographies with Selco as well as other partners. Could you talk maybe about the work of some of your partners, and what has been their experience of adopting DRE to address their needs?
Thank you, Harsha. The good thing about speaking later is a lot of the good things are already covered, so I don't have to go there. And also, after hearing about Preeti ji's experience, it's very difficult to, talk about something that emotional and that important. Okay, 2 of my most important partners here are present in this panel, WRI and Selco Foundation. Of course, I'm going to talk a little bit about some of their works. But before that, let me, I don't know if everybody knows, I work for a private philanthropy called Good Energies Foundation, which is part of Porticus. And I manage their work for the clean energy portfolio. We basically have 2 focus. One is serving the underserved and helping the organization that serve them. And in the same principle, we started working with organizations in India who basically deliver in this juncture. And I want to make sure that I don't deliver any work on the ground, so I'm not an expert, and I'm just lucky that I'm sitting around some experts and they have talked about their experience. So before talking about, I actually don't want to mention each of the partners and then their work, but I want to highlight one point, which is a shift in the healthcare system that we have observed, that is not just thinking about renewable energies or solar power, rather rethinking the healthcare system, particularly the healthcare equipments. It is very important to have equipment and machineries, everything that works in a clean energy installation. I think Dr. Bhushan also mentioned this, even Lanvin discussed this in his presentation, that not just the means of energy, it is equally important to have that kind of machineries in place that can work in that kind of setup, particularly off-grid and in the weaker grids in countries like India and beyond. And I think some of our partners were able to do that, were able to deliver that, and that's why that's where all those successes came from. Of course, I have to mention Selco, and Nirmita spoke about the work that they are doing, in 11 states in India now. It's a huge number, and I think some of the successes were also responsible because they worked for that grassroots, high efficiency, low cost machineries solutions that are adaptable across different states. Right, and I specifically mean rural healthcare system here, where robust and easy to fix systems can work with to 80 to 90% use coverage, as opposed to, in the city setup where the efficiency is expected 100%. So my point here is not just the infrastructure itself powered by any kind of renewable energy or solar, but it is also equally important to have efficient systems and equipment that can work in that sort of setup. Right, and I can also speak a little bit about our cross-border learning experience, not just within India. And of course, I mentioned CELCO WRI. We also have other partners, Council for Environment, Energy, and Water, Power for All. But beyond that, another partner called Healthcare Without Harms. They were founded 25 years ago to address the toxic waste in the healthcare system. But in India, their mission is to emphasize on the sustainable practices in the healthcare system. Again, they are partnering with another organization called CLASP, CLASP, to come up with efficient equipment, including medical devices, lighting, and cooling solutions, etc., which are locally adaptable and that. And also they're partnered with CELCO, and they're procuring some of the they're doing some of the pilots with CELCO to check whether those machineries work in off-grid or very weak grid settings in India. And the knowledge they are going to generate from this work, they are going to disseminate that within their Global Green and Healthy Hospitals Network, which is global, and beyond other countries and also some other large-scale institutions. So that's their work. So I would like to take a pause here.
Sure. Thank you, Maheno. I think you're right. It's not just the infrastructure. It's also about what uses that infrastructure, the equipment that will actually provide the services. Thanks for that intervention. Let me turn to Benson. So Benson, I'll put forward two questions for you because we're running out of time. You can, you've been doing similar kind of research on health and energy in sub-Saharan Africa and East Africa. And could you talk a little bit about, some important aspects that we should keep in mind when we are planning healthcare electrification? So whether it is we've heard about the policy sort of research that we've done here, but are there any other requirements for planning, particularly like maybe data or other technical considerations? And also, if you can identify some innovative approaches that you are seeing in that region, which could be useful for cross learning here.
Yeah. All right. Thank you so much, Harsha. So my name is Benson Ireri, as I was introduced initially, and I lead the energy access work for WRI in Africa. So I guess one of the most exciting thing, just to thank my colleagues here, Harsha, Lanvin, Bharat, whom we've been working very closely together with the rest of the colleagues, is that there's so much similarity I see between India's experience in terms of healthcare electrification, but also more important in terms of the connections and the experiences that you guys are learning in terms of healthcare electrification interventions or the work around there. But I think just to set the context and building into what Bharat started by initially alluding to, I see so many similarities. 28% of healthcare electrifications in sub-Saharan Africa, which translates to almost around 50,000 healthcare facilities, don't have access to electricity. Now, the critical thing is majority of those facilities are actually in the rural parts. So when you're speaking about people or the impact of our work on people, what exactly does that mean? If then we are having facilities that are not electrified and they're actually supposed to deliver healthcare services or quality healthcare services to the populations for that matter. But also the other thing is even the ones that are connected to electricity, reliability is still a big issue. Now, I think the implications for that is two things. One, again, how often do these facilities fail to deliver healthcare services to the population? And for the private healthcare facilities, one of the key things that we have realized, again, is because of the lack of electricity or reliable power, is they end up investing again in diesel backup generators. Now, again, if you're looking at it then from an impact or an environmental plus climate impact, what does that mean? in terms of then all these facilities, again, having to rely on diesel generators, number one. But I think also number two is the implication of the cost of diesel, which continuously goes high. What does that mean in terms of then eating into the health budget for these facilities, and the implication for that in terms of then providing or expanding even healthcare services? So I guess then where does the role of data come in into this? And I think I want to respond to my brother's question that he raised here. Where do we direct these investments, or how do we direct the decision making in terms of healthcare electrification? And I think the role of data for us then demonstrate. I mean, the beauty about it is that if you can be in a position then to map out where are these facilities, where exactly are they located, and what is the electrification status? Because I think from a policy planning perspective, unless then you can be able to demonstrate to policymakers where these facilities are, then you can be pretty sure in terms of planning, in terms of resource allocation, it's going to be skewed, and you cannot be in a position to do proper planning without access to reliable data. And I think for us, mapping out where these facilities are, what is the electrification status, but also more important, what are some of the least cost options in terms of electrification, I think has proven to be quite reliable, both in terms of policy planning, but also even for institutions like World Bank that we have been continuing to partner with. ISA, for example, in terms of demonstrating then where are these facilities, what is the electrification status, and where the priority is supposed to be directed to. But I think also more important is even in terms of piloting these interventions, some of the other things that we have realized which is quite critical. And I think, sorry to say this, especially in the presence of the philanthropic funders, is one of the challenges that we have realized is majority of these or the grant-funded interventions, the facilities don't have the capacity to actually do the right energy demand assessment. And as a result, what that therefore means is you have a facility either with the sizing was done wrongly, and so it's either the system that was installed either small, or it's actually way bigger, that it's generating more energy than it's actually required. Now, I think what is even more important is the one that is downsizing, or the sizing that was not done correctly, and so the energy source, generated is not sufficient. The implication is that frustration, we have seen significant frustration with the healthcare facilities, that you come here, you've supported me to install a system that does not meet all my energy needs. And so the negative connotation in terms of solar, for example, does not meet the right or the energy needs for the facilities. What does that mean? And how do we also then support in terms of changing this narrative, but also more important in terms of then supporting the system sizing, so that then the intervention that is actually put in place helps to meet the requirement or the needs for the community. But also more important, even from an oversizing system, is that what we have realized, especially from a private sector healthcare electrification perspective, is that the moment you support or you don't support the facilities to then do the right sizing, and they end up with a huge system that they don't need, you actually then are obligating them to pay for a system that they don't require. And so you actually then posting another immediate imagination that solar electricity is quite expensive, which is not necessarily the case. So I think getting to understand what are the energy needs, number one, and number two, what is the right size of the system, for example, that would be required to provide electrification, I think for us has proven to be quite important. But also number three is even in terms of then meeting the costs, I think there's a significant, huge opportunity for financing, or the need for financing for that matter, sorry. The one thing that we definitely have to appreciate is that there's a significant role for private financing. Now, I think the opportunity for debt, as Landvin was speaking, and how do we then blend this financing, and what's the role of public finance, what's the role of development financing institutions, for instance, again, in terms of helping to de-risk the investment that is in there. We have realized, certainly, I think there is need for us to come up with the innovative financing mechanisms, quite critical. But also number two is the whole question about how do we de-risk the private capital that is available, because we realize this significant opportunity from local financing institutions, but then their perception in terms of risk becomes a critical aspect. And so looking at how we can be in a position then to help in terms of de-risking local private capital becomes quite critical then to help unlock financing for healthcare electrification.
Thanks, Benson. I think you've raised some very important points, especially on the oversizing, undersizing issue, and then that has costing implications, because if you're undersizing it, then you're actually paying double because your system then fails to actually meet your needs. So I see that we're sort of running out of time, but I will ask maybe one question or a couple of questions, and then panelists to maybe respond to it. Maybe I'll start with Preeti ji. So, because you've recently now implemented your installations, what is your plan to actually maintain them and sustain them for the next 20-25 years?
हमें सोलर इंस्टॉलेशन हुए हैं, उससे काफ़ी फ़र्क पड़ गया है और राहत मिली है नर्सेस को भी. नर्सेस क्वार्टर में नहीं थी. क्लिनिक्स में बहुत ज़रूरी इक्विपमेंट है कि ज़रूरी लैपटॉप पे वो रिचार्ज करें, तो अब वो ब्लड सैंपल कर सकते हैं, सीरम सेपरेट कर सकते हैं, बहुत सारी ऑक्सीजन कंसंट्रेटर यूज़ कर रहे हैं, बेबी वार्मर यूज़ कर रहे हैं. एंड साथ ही उनके जो रेजिडेंट्स हैं, क्वार्टर बने हुए हैं, वहाँ जो रहती है 24/7, तो उन्हें भी राहत मिली है. लेकिन वही बात है कि बहुत सोलर इंस्टॉलेशन होने के बाद उसकी सेवा लेना, उसका उपयोग करना भी एक बहुत बड़ा चैलेंज है. जो मैं बता रही हूँ कि दूर दराज के क्षेत्रों में हमारे क्लिनिक हैं, उस जगह वेंडर जाना बिल्कुल इंटरेस्ट नहीं रखते हैं. तो जब WRI ने वेंडर के साथ बहुत अच्छी तरीके से बहुत एक्सरसाइज करी और मैं कई जगह फ्री हो जाती थी कि वो आपस में ही बात कर लेते थे, तो 5 years मेंटेनेंस के लिए बिल्कुल तैयार नहीं हुए. लेनविन ने भी बताया कि 1 to 5 years रेंज करता है, तो 1 साल के लिए उन्होंने तैयार हुए हैं कि वो भी देखना चाहते हैं. सब गिव अप कर देते हैं कि इतना दूर ट्रांसपोर्टेशन बहुत महंगा पड़ता है और उसमें कोई भी कंप्लेन है तो कंपनी के इंजीनियर को जाने में भी टाइम लगेगा. तो 1 year मेंटेनेंस का अभी कॉन्ट्रैक्ट एक हुआ है. एंड सस्टेनेबिलिटी अगर हम देखते हैं तो एक तो फंड का है ही ऑब्वियसली कि जो AMC का कॉस्ट है वो हायर होता है. एंड जो भी फंडिंग है, हम लोग 10-12 डोनर्स हैं जो पूल बजट है फंड करते हैं, उससे क्लिनिक अलग अलग इश्यूज पे होता है. तो एडमिन कॉस्ट या लॉजिस्टिक्स कॉस्ट के लिए ऐसा कोई फंड नहीं, कम ही होता है. डायरेक्टली न्यूट्रिशन पे होगा, TB पे होगा, मल न्यूट्रिशन पे होगा, और चीज़ों के लिए होगा. तो वो कॉस्ट निकालना बहुत मुश्किल होता है. तो हम लोग ये सोच रहे हैं, एक तो सबसे पहला तो कि कहीं ना कहीं क्लिनिक में ही जो हमारे प्रोग्राम हैं, जो क्लिनिक एक्टिविटीज़ है, उसमें एक तो बजट करेंगे. दूसरा, इलेक्ट्रिसिटी बिल भी अगर रिड्यूस होते हैं, कुछ थोड़ा सा माइनर एक हेल्प होगा कि अगर बिल उसमें रिड्यूस होते हैं, तो एक हाइब्रिड सिस्टम इसमें कैसे होगा वो मुझे बताया, लेकिन मैं थोड़ा कंफ्यूज हूँ, बाद में आपसे पूछूंगी. ये है. तीसरा ये है कि हम जो हमेशा कम्युनिटी पार्टिसिपेशन, भागीदारी में जो क्लिनिक काम कर रहे हैं, सामुदायिक भागीदारी में है, जहाँ पर कि जो इंफ्रास्ट्रक्चर है वो भवन, पंचायत भवन से ही हमने उनका भवन लेकर के रेनोवेट किया है, जो बिल्कुल जर्जर था, और उसको रेनोवेट करके काम चला रहे हैं. तो और भी पार्टिसिपेशन हम देखते हैं नर्सेस के रहने में, कम्युनिटी में, पेशेंट के लिए रेफरल में. तो उनके साथ भी हमारी एडवाइजरी कमेटी है, तो पंचायत के लोग हैं, लोकल पीयर ग्रुप से, तो हम चाहते हैं कि उनका इन्वॉल्वमेंट भी पावर बैकअप की तरह रुझान हो, उसकी महत्व पता चले, कितने काम हैं, तो वो भी उनके स्टेक हों. और भी जगह जो पोटेंशियल सोर्सेज है, अटल सेवा केंद्र है, स्कूल से, वहाँ लगाए जाए, ताकि वेंडर्स आ सके, उन्हें भी बिजनेस मिले, एक तो कि और हमें थोड़ा काम मिल रहा है. और उन लोगों में भी एक कॉमन बड़े यूनिट भी शायद इंस्टॉल किए जा सकें, जो कि कुछ लोगों की खेती भी है थोड़ी बहुत, कुछ लोग और भी काम कर रहे हैं, तो उन सबको बिजली के बिना बहुत दिक्कत है. सरकार ने कई जगह कुछ स्कीम में दे रखे हैं, एक पंखा एक लाइट जलती है, लेकिन वो सब जगह घरों में प्लेट्स पड़ी हुई हैं, बिकॉज वो दे तो दिए, लेकिन उसके बाद वहाँ पर मेंटेनेंस नहीं होती है. तो हम चाहते हैं कि हमारे जो कैचमेंट एरिया है वहाँ पर तो सस्टेनेबिलिटी में एक ये भी पार्ट हम देख रहे हैं कि मेंटेनेंस हो, और कुछ सब्सिडी कहीं पर, जैसे जो वेंडर्स हैं, या एक तो फंडिंग जो है वो उसका तो हमेशा एक रहता है कि कुछ फंड भी मिले, और साथ ही पंचायत और जो उनके पास जो फंड अथॉरिटी है, पॉलिटिकली देखें या जैसे भी, तो वो उसको यूज़ कर सके, उसकी महत्व समझ करके. एंड लोगों की अवेयरनेस, जानकारी हो कि इसका उपयोग कैसे किया जाए. ट्रेनिंग भी एक सपोर्ट चाहिए होता है सस्टेनेबिलिटी में, कि लोकल टीम उसको कैसे हैंडल करें. चाहे आप एक बार ट्रेनिंग कंडक्ट कर देते हैं, क्वार्टरली ट्रेनिंग होती है, लेकिन फिर भी जो टीमें नहीं समझ पाती है, तो ये एक
Thanks Preeti ji. Just to quickly summarize, she said that of course staff is able to use the installations now, and they can improve upon their services. But the reality is that vendors are not really keen to provide AMCs in these remote areas. And so what they would like to do is actually involve more local committees to understand what sort of installations have been implemented. That will hopefully create additional opportunities for these vendors. More installations can come into these particular areas, and then that will create a reason for these vendors to actually start servicing these remote areas, because that support is something that's really, really critical to operate and maintain these installations. And of course, she said that awareness of the local population, as well as training for the local team who is actually operating in these clinics, is also really, really critical for these installations to survive and sustain for the next 25 years. Maybe I'll pose the same question to Nirmata, because now that you have 25,000 facilities being covered in your programs, so what is your plan for sustainability across these sites?
Given a little bit of a background to the 25K, because it's a big program that we've launched with the Ministry of Health and Family Welfare and IKEA Foundation, and it's 25,000 by the year 2026, which is a very short time frame, and it's the largest program in the world right now on powering of health facilities in such a tight time frame. Our core objectives are quite simple. We're looking at 100% clean energy, decentralized energy sort of powering of facilities. 10,000 of these health facilities are also going to be looking at future-ready medtech, that is point of care, telemedicine, remote monitoring systems, green built environments, full comprehensive sort of model health facilities that we're looking at. And I know that 25,000 sounds like a lot, but still only 12% of the entire sort of health infrastructure in a country like India. But a lot of our learnings from this are hopefully going to, cater to, I'm hoping to sort of say that, catalyze a lot more health facilities being powered in the country itself. We're also looking at these models being showcased through our partnerships with our African country partners. So that's something that I think we should also discuss separately. We were working in Burkina Faso, Sierra Leone, Tanzania, and Ethiopia, and looking at similar programs being sort of rolled out there. And the intent over here is to look at, like you said, very critically developing, using this philanthropic monies that we've raised to roll out very robust sustainability, like scalability programs, right? By which I mean, we are focusing a lot more on operational and, maintenance models. We're looking at different kinds of ecosystems that we have. What does it take to sort of deploy in a context like Mizoram, which is a state that we're working with very hands-on, right? Still sort of really heat-stressed districts and, remote contexts that need to be sort of looking at O&M in a different manner. So there we're looking at even like different managing systems through sort of ZPCEOs, DCs, looking at localized O&M systems. So those are some of the sort of ways that we're looking at strengthening, rather using philanthropic money to strengthen systems that could be scaled, so that we have health facilities at the last mile that can own. And big part of it also looking at catalyzing local philanthropic and domestic monies also, is basically showcasing these models to see how can we sort of potentially link directly to governments to be able to then own these systems and deploy these models on the ground.
Yeah, thanks. That's very important. So different kinds of O&M models related to each context, and that probably will ensure that different needs are met, even though the overarching framework might be the same, but each gets its own interventions. Mahina and Romit, maybe I'll combine a question for you, which is that of course you've shared your learnings from your partners, and how it is different to do maybe non-energy interventions, and different to do energy-focused interventions. But in your opinion, how can the impact from these kinds of things, these kinds of interventions, be communicated a little bit more effectively, so that more finance or more funding can actually come to this particular sector? So maybe, Mahina, do you want to go first?
Good. I would like to go first, sure, because I have something for you. So, okay, I'll be brief, and then I'll talk about probably 3 aspects that I think probably work. The first is holding hands and connecting all the good works of everybody, all the key players in the sector. Let me go back to my previous example of healthcare without harm. What they are doing probably is going to be effective. Remember, in the past 3 years, some of our partners, Selco foundations, have developed a lot of energy efficient solutions and really resolved a lot of grassroots levels issues, while our other partners, for example, Council for Environment, Energy and Water and Power for All, advocated for distributed renewable energies in healthcare system. And now this partner, Healthcare Without Harm, is going to disseminate this knowledge globally. So this could be one way of disseminating more information, drawing out different diversified funders, not just depending on philanthropies. And then secondly, as I'll go to you, Romit, which is about showcasing these good examples, showcasing your works to other corporate funders, particularly the domestic funders, CSR or India's local domestic philanthropies. This could be another way. That's the second. And my last is, I'll go back to what I said in the beginning in my first intervention, is framing the issue. How about we do not even mention decarbonization? We just simply say efficient or better healthcare system. Why I'm saying that is, if I attach to some of these connotations, energy, climate change, then only certain kind of stakeholders will get attracted to these issues. And different funders have different priorities. I understand that philanthropic money in the initial riskier interventions and innovations are very important, but we have to keep in mind that philanthropic money, particularly like ours, a private philanthropy, are very short term because it's private money. So the focus or the strategy can change. And then, as you mentioned, sir, that it's grant money. So it's here today and there's no sustainability for that kind of money. So for that, how about we focus on efficient or smarter or whatever you call it healthcare system? So the means of energy is not important. It is important like how we deliver the system. So yeah, thank you.
Thanks, Mahina. Romit?
Thank you, Harsha. I'm mindful of time. I'll be very quick. So I think I want you to picture this, in terms of the overall CSR pie that is spent in India, 35% of the intervention is on healthcare. But this is not. So can energy transition in healthcare be a narrative that can be developed? Of course, this will involve a whole set of engagements and interaction, but one key aspect to that, which you also touched upon, is to creating that value proposition. So while of course I invest in healthcare, why investing in energy transition and healthcare could be a great opportunity for the larger CSR community to invest. I'll also make a point here that whether it is CSR, a lot of things, and don't quote me on this, things are getting regulated within what can be done, what cannot be done. So here the whole aspect of blended finance. So where say a CSR could put in money, but say where a private philanthropy could put in money for aspects like capacity building, for aspects like O&M, because the way we could use our money on CSR is also being regulated. So are there ways where different pots of money can address different aspects? So some of the concerns that were listed here can be addressed. And I said in that the value proposition, every organization has an own theory of change, but like the role that you have as to play is to kind of how do you convene this different theory of change into one unison which can create impact. I also want to leave a thought around the whole aspect of priority sector lending. A really large part of our balance sheet, and for any bank's balance sheet, is around priority sector lending. There are, I was reading the guidelines on PSL. There is, an area mentioned around healthcare, but but those have to be looked at more on models of creditworthiness, the ability. But is it time to also look at advancing the discourse on priority sector lending? Because when we talk of financing, there is, this is also this pot of money, but we don't know how and who to give. So I'll pause there.
Thanks, Romit, and thanks, Mahina. Those are very important points. And finally, let me come to Dr. Bhushan. So, sir, I think you've heard a lot of us make, very impassioned, entreaties in terms of how we can take forward this sector. But if I could ask you to maybe figure out some key messages from what we've heard today to actually convey to, let's say, the government at the state level, what would you suggest, to convey to them?
First of all, I would like to say and convey that people like Preeti ji who are there working in the grassroots level, they are very few people. They are the icons and they are the torch bearers. So unless it has a systemic approach, wider effect and wider acceptance of the this initiative will not be there, and it will be difficult. All the points that you have said, even the CSR has the limitation. They can give you one time support, but expecting them to maintain this thing for 25 years, 30 years is not possible. So we have to have a systemic approach, and there are the systems there. It's not that system is not there. System is built in. Like we talked about the equipment maintenance and the maintenance of the solar. Already Government of India has a program for biomedical equipment maintenance program. And what we have calculated is around 4% of the total equipment's budget, if spent on this, fault-free, equipment maintenance can be done. And why not this solar equipment can be part of that? So there should be will by the states and the government. From the Government of India, I mean, there is no problem. It's not the problem here at the ground, because we are only giving the funds, and it is the proposal from the states. Similarly, the infrastructure. Whenever we talk about the infrastructure, everybody is interested in creating and showcasing these many buildings, these many district hospitals, MCH buildings have been built. When I go down the line after 4 years, 5 years, the conditions are not so good. So how to maintain it? Now Government of India again has this opportunity. They have said to the states, government has said that a particular percentage of the total infrastructure, as you feel, you can ask us as the flexi fund for the maintenance of the infrastructure, and then you can do it. Because there are the lifts operating. It's not only the solar electricity. So in the system, as far as the policy is concerned, those systems are there. But but how to leverage those systems, and how we have the untied grants. We talk about the sub centers. So all the health and wellness centers in the country at the 5,000 population has the 50,000 untied ground. No questions asked with the CHO. You can use it for whatever the local needs are there, but you have to utilize it. You have to empower them, and that advocacy. It should not be that some auditor comes and he starts. They are the not that way forward looking and highly expocable persons. So there should not be any stick on that, and the provisions are there. So in my opinion, what I feel is that as far as Government of India is concerned, if you have a robust plan, if you have the robust system, operational guidelines are there, the specifications are there, you have already given the energy calculation model, but can be also introduce some of the modules, like maybe that mobile chargers. I am just saying, everything is needed. Maybe the geysers may not be the immediate requirement, but maybe the critical. So we can modulate that what the sub center may need minimum, what the PHCs may need minimum, CHCs may need minimum, and then with these modules we have to meet the states, and the advocacy should not only from this group, but also it should be from the country highest level, that is the Government of India and the mission. Then probably it will sustain.
Yeah.
So systemic approach, what I feel, and provisions are there. Utilizing these provisions for the best use will be the right answer. Thank you.
Thank you so much, Dr. Bhushan. And with that, we conclude the panel. I want to turn to the audience for their interventions. We are running out of time, so maybe we limit to 2 interventions at the most. So,
एक बात बोलना
Sure,
चाहूंगी।
sure,
अभी
sure,
सर,
Preeti ji.
डॉक्टर
Yeah.
हिमांशु ने जो बोला, मैं एक पॉइंट रेज करना चाहूंगी सर। आप जो पॉलिसी की बात कर रहे थे कि डायबिटिक पेशेंट जो आते हैं, आजकल गांव में भी, हम लोग जब शुरू किया था तो नहीं थे, अभी वहाँ भी हाइपरटेंशन डायबिटीज खूब है। तो उन मरीजों के लिए जो इंसुलिन है, हम लोग इंसुलिन पेन वगैरह बड़ी मुश्किल से उनको देते हैं, लेकिन वो उसको कोल्ड जो टेम्परेचर है उसको कैसे मेंटेन करें, तो वो भी एक इशू है कि बहुत मरीज हैं और जिनके इलाज हम लोग करने को तैयार हैं, उनका बराबर फॉलोअप भी है, लेकिन एक तो ये चैलेंज है। और एक जो फुलवारीज चलती हैं बच्चों की, जहाँ मदर नरेगा में और फायरवुड के लिए जाती हैं, उन बच्चों के लिए फुलवारी है तो एक लाइट एक पंखा जले, ऐसा कहीं सोलर का हो।
Sure. Yes. Nashwa.
Hi, thank you so much. It was a very, very brilliant panel discussion. I'm Nashwa from SE for All. Glad to be here. One of my questions, and different people touched upon this on the panel, how much is training and capacity building a gap in healthcare electrification, and how much is that included when we're looking at financing of it?
My name is Munir. I'm from the World Bank. I just had a thought, just taking from some of the points that were raised by Dr. Himanshu Bhushan sir. I suppose, I hope, I believe that some of us are aware about this program, the National Program on Climate Change and Human Health, which is led by the National Center for Disease Control. Under this program, there is a guideline on green and climate resilient health facilities that are prepared by the National Center for Disease Control, that's prepared by NCDC under this program. And within this program, the states are also expected, and some of the states have already prepared the state action plans on climate change and health. And the states also have state task force and district task force on climate change and health. Just a thought, a suggestion that, since there is already a systemic engagement here, especially in terms of the guidelines, I think it would be good to integrate this with some of the existing flagship programs of under Ministry of Health, like PM Abim, Ayushman Bharat Health and Wellness Centers. So, taking from there, it would be also great to sort of bring about a platform where we have, some of these existing best practices that are there, which were already discussed, some of the existing, interventions at the state level also, to sort of bring this under a common platform would be great, because we should look at sustainability at the end of the day and to sort of integrate it in a systemic manner. Just a thought. I would like to hear from Dr. Himanshu Bhushan sir and others on this.
So as far as the training and financing for the solar part is concerned, see, capacity building is one of the big arm of the government of India under the National Health Mission, and a specific funds can be asked under the program capacity building. When we talk of the capacity building, it is not only the technical capacity or capacity, clinical capacities. These are also the capacities like training of HASA, capacity building of other things, and the finance will automatically be built upon that. So that is not the problem. So these opportunities are there. What is needed is that it should be cost effective, it should be productive, and then it should be acceptable. So you have to work with the system, with the program officers and the state in reflecting that. Now coming to you are right, 100% right. So I was also part of all those activity and group. We worked together with Dr. Akash and the whole team. So first information which I would like to give it to you, that before this, the climate resilient infrastructure part and what should be, because we have to understand from the perspective of a civil surgeon. When we talk of the civil surgeon, he is the head of the district health. So what he should do, we have to talk from the health perspective of a medical superintendent who is in charge of a hospital, what he should do, because resilient climate, it takes many of us to understand what all it includes 1 year, even for a common persons like us. So for them, so in a simplified way, 10, 15, 20 points which we work with the NCDS is now part of the Indian public health standards. So again, that policy is there, like all energy saving bulbs that is required, rain harvesting and all those points which were there, that is the part of the Indian public health standards, and the detailed guidelines is already there, as you rightly mentioned. And again, for the funding for this, already under the finance section of the National Health Mission, there is a separate head given under the climate resilient infrastructure plan. So states are free to reflect this under that head also. So what I am trying to again and again convey is that government's commitment and the policy and the systems are in place, But of course, I do agree that systems are in place, but operationalizing the systems, taking benefits out of the system is like the tea is ready, but you have to sip. So that is the point, and people like you will have to help with that. Thank you so much.
Thank you, Dr. Bhushan. Would anyone else like to respond to the question?
Yeah, I did have. So I just wanted to maybe mention a project with a program that we're doing with the state of Meghalaya, right? So under PM Abhim, they are rolling out 300 new health facilities, health sub-centers, and we have been sort of supporting the government over here to design those health facilities. So this is looking at climate smart, even sort of looking at what is the best place to locate those health sub-centers, because Meghalaya as a state is highly sort of disaster prone. So location of health facilities, how do you design them for earthquake resilience, cyclonic activity, basic energy efficiency principles and things like that, and looking at sort of unlocking PM Abhim as part of that whole programmatic approach. And the main sort of core stakeholder over here was for us the health department, the CDMOs, the medical officers at the PHC levels, and they were sort of very sort of participatory in the whole approach of designing these health facilities along with the community. So the way we are rolling it out also is in a very different manner, where it's not a traditional tender process. We're actually looking at training and capacity building of the NREGA workers, which in Meghalaya is a VEC members, to sort of be able to then build and own the system, the health facilities. So investments are in the community itself, and B, you are sort of skill upgrading and are able to ensure that in the long run the buildings are also maintained by the local NREGA workers itself. So that's one case I just wanted to highlight.
Thanks, Nirmata. And so with that, we come to a conclusion for this particular panel discussion, and thank you everyone for joining us. I want to invite Jennifer to give the closing remarks. Jennifer is the Global Director for the Energy Program at the World Resources Institute.
Thank you, everyone, for staying even as we've run long. This has been a wonderful session. I congratulate the panelists and my WRI colleagues for putting together what I think has been an incredibly important discussion. Panelists that represent a spectrum from across the health and energy stakeholder community, providing with an idea of the level of priority that planners, policymakers, and financiers, as well as healthcare sector itself, must take for integrating the kind of technology solutions that will provide patients better care, the faculty and facilities with the resources that they need to be as excellent providers of choice. We know that, in fact, these communities are often invisible in terms of their role in playing both for climate as well as for thinking about the development needs. But every person who enters those facilities benefits. And we know that 1 billion people around the world are served by health centers that don't have energy. So each one of those individuals could be harmed. It's critical that we think about how our corporate social responsibility, how our philanthropy, how our policy, and how our health institutions begin to integrate in these kinds of core services. And I was struck by the conversation around whether and how we speak about this, if this is a climate benefit or if this is a human benefit, a catalyzing energy transition for healthcare. And that to me feels like a vision that allows us to integrate this not in what may be considered to be a mitigation action, but rather as a central part of our healthcare agenda, helping evolve the business models, helping to change the services and the type of services and strategies that healthcare facilities can take forward. And this has all been touched on in our conversation: the need for data, for finance, for budgets, for operations, and for enabling business institutions to serve these communities better, to serve these health clinics better. So how we meet their needs, how we collectively work together to create community participation, to help bring these types of benefits into our business models for each of us is a challenge and an opportunity that I am eager for us to continue working on together. Thank you so much for this panel and to all of you for your leadership in this area.